Okay, welcome everyone. Today we're doing a deep dive into a really challenging condition, chronic thromboembolic pulmonary hypertension. You might know it as CTEPH. We've got some excellent sources you sent in, and our goal today is, well, to unpack this complex vascular disease. We'll explore how these old blood clots cause high pressure in the lungs, and then we'll really focus on a procedure called Balloon Pulmonary Angioplasty, or BPA. It's become a vital treatment, especially for patients who didn't have many options before.
Yeah, it's a truly serious disease. It's classified as Group 4 pulmonary hypertension, and historically, if it was left untreated, particularly with that mean pulmonary arterial pressure, the MPAP, over
30 millimeters of mercury, right?
Exactly, a key number. If it stayed above that, the prognosis was, well, pretty severe, often led to right heart failure. We're talking maybe only a 10% survival rate at 3 years for many. And it all stems from basically acute blood clots, PEs, that just don't dissolve properly. They stick around, turn fibrous, and kind of become part of the artery wall, blocking things up.
Okay, let's talk about the standard treatment first. For a long time, the go-to has been pulmonary endarterectomy, PEA.
That's right, PEA.
It's a big surgery, highly specialized, where they actually go in and remove those organized clots. And the results can be amazing, right? Like a 90% 5-year survival in top centers.
Absolutely. When it works and for the right patient, it's curative.
But, and this is really the crux of the issue, isn't it? A huge chunk of patients, maybe a third, sometimes even over 40%, they're told they're inoperable.
That's the key problem, inoperable.
And that could be because the blockages are just too far down in the small arteries for surgery.
Exactly. Too distal, surgically inaccessible, or sometimes the patient just has too many other health problems. Maybe they're very frail or have severe COPD, making that big surgery far too risky.
So what happens to those patients? That's where BPA comes in, right?
Precisely. This is the group BPA really helps. Now, it's interesting. The first attempts at BPA, way back in '88, well, they didn't go so well. High complication rates. Yeah, but things changed since around 2004, mainly thanks to much better imaging technology and, refining the techniques.
The imaging.
Huge difference. It's made BPA much safer and really effective. It's become a critical alternative, a lifeline for many.
So let's visualize this. How does BPA actually work? It's not like PEA where you take the clot out.
No, not at all. With BPA, you don't remove the material. Instead, you use a balloon catheter. Go into the artery, inflate the balloon right at the blockage, and you essentially mechanically dilate the artery. You're pressing, sort of crushing that fibrous material against the vessel wall.
So you're just pushing it out of the way to open the channel, remodeling it from the inside.
Exactly. Remodeling it is a good word for it. You're restoring the pathway for blood flow.
And you mentioned imaging is key here. How so?
Oh, it's absolutely paramount. From the moment of diagnosis right through the procedure itself. We have tools now like IVUS, intravascular ultrasound.
Using sound waves inside the vessel.
Right. And OCT, optical coherence tomography, which uses light. They let us measure the vessel size incredibly accurately, see the lesion really well. Plus, things like cone beam CT give us clearer pictures of these tricky blockages, like webs and bands. All this precision helps guide the wire safely, choose the right balloon size.
And avoid complications.
Exactly. It dramatically reduces risks like damaging the artery.
I understand this isn't usually a one-and-done procedure. It's often done in stages.
That's right. Typically, it's a staged approach. Multiple sessions, usually spread over several weeks. Could be anywhere from, say, 2 to 5 sessions, maybe sometimes up to 10 in complex cases.
Why do it that way?
It allows for gradual improvement. You dilate different areas bit by bit. This maximizes the benefit, but crucially minimizes the risks, especially the risk of something called reperfusion pulmonary edema.
Okay, what's that exactly?
It's basically fluid buildup in the lungs. It can happen when you suddenly restore a lot of blood flow to an area that hasn't had much for a long time. The staged approach helps the lungs adapt, makes the whole process much safer.
Right, makes sense. So connecting this back to the patient, what are the outcomes like? We talked about the pressure.
The outcomes are generally really impressive. Studies consistently show that pulmonary artery pressure drops significantly, from maybe 35-58 millimol Hg down into the 18-36 range.
Wow, that's a big drop.
Huge. And pulmonary vascular resistance, the resistance the heart has to pump against, that drops massively too, by over 300 units often. Takes a huge load off the right side of the heart.
And for you, the person living with this, what does that feel like?
It means a massive improvement in quality of life, generally. Functional capacity goes up. People can walk further. That standard 6-minute walk test distance improves by about 70 meters on average.
So less shortness of breath, more energy.
Exactly. Most people move to a better functional class. They go from being severely limited to actually being able to do much more, enjoying life more. Now, complications can still happen, vessel injury, that reperfusion edema. But with modern techniques and careful management, the rates are much, much lower than they used to be.
It really sounds like the evolution of BPA is a fantastic example of innovation, especially how imaging just transformed a procedure. It's opened doors for patients who, frankly, didn't have many.
It truly has. It's shifted the landscape for inoperable CTEPH.
Turning inoperable into treatable.
Precisely. But there's a final thought here, something interesting to consider. While BPA is great for these larger proximal blockages, CTEPH seems to be a bit more complex. It often involves both these big blockages, the macrovascular stuff, and changes in the tiny blood vessels, the microvasculature.
So it's not just the big pipes.
Potentially not entirely, which raises a question for the future, Could the very best way to manage CTEPH actually be a combination approach?
Like mixing therapies?
Yeah, maybe using surgery like PEA where possible, BPA for other areas, and targeted medical therapies, tailoring it precisely to each individual patient to hit all aspects of the disease. Something